So what's the epidemiology a little bit for spondylolysis? Well, if we look at young athletes themselves, and I would say this literature is still, I think, relatively accurate as a reflection of my own practice. In looking at 62% of identifiable causes in young athletes, spondylolysis was the kind of most responsible for back pain. Unfortunately, I am finding that the percentages of my patients that are actually choosing to do athletics are going down. So what are the risk factors for spondylolysis? Well, it really comes basically based on how much hyperextension is done in the sport, and whether you're a diver, a weightlifter, a gymnast, and a rower. And it really kind of goes against or goes with all genders. And it doesn't necessarily matter the intensity of this sport, is what I've noticed, just the participation in the sport. There are also familiar forms of spondylolysis, and you can actually see this with, based on some ethnicities, with Inuit Eskimos actually having up to 50% incidence or prevalence of spondylolysis, with the lowest then reported among African Americans. In terms of my own population, I would say that the vertebral level is inaccurate, with almost 90% of them occurring at L5 or the L5S1 junction, and then kind of decreasing in number as you go cephalad. So what's the clinical presentation for spondylolysis? Well, it comes in a couple different forms. I actually have a decent amount of patients that come to me with their parents because they're otherwise asymptomatic, but they're seen incidentally, and so they're seen on either scoliosis X-ray or an abdominal CT for API, for example. But in terms of the symptomatic presentation, it's usually an adolescent with low back pain. It's activity related, worse with back extension. What I do show is this, I do have a few patients every once in a while that come with an acute incidence of a spondylolysis, and they actually will present with radicular symptoms, and I'll go into that a little bit shortly. So what's the imaging? So typically start off with obviously PA and lateral lumbar X-ray. We're looking for that little circle there. My subsequent imaging, if I don't see it on a X-ray, and if I am concerned enough for spondylolysis, I'll consider getting an MRI, which has greater than 80% sensitivity. It's also able to diagnose stress reactions, which are pre-fractures, and the advantage in this population of young patients is no radiation. So CT still remains the gold standard. Obviously, there's more radiation associated with it. And in my hands, that typically is done mostly for surgical planning. So I think what's important is actually the imaging that's no longer recommended. And that includes, probably still on the OIDI is looking for a Scotty dog's collar on oblique X-rays. I have not gotten oblique X-rays in years, if not a decade now. And that's because of the concern for double radiation exposure from two additional X-rays. The thing that's really strongly recommended or discouraged now is actually the use of bone scanner SPECT, and that's, again, because of 7 to 8-fold radiation exposure. So what is the non-surgical management for asymptomatic spondylolysis? It's basically education. I don't restrict their activities, even though parents and families are concerned about them becoming symptomatic. Actually, what they're really concerned about is they want this to heal, and if they think they can restrict the activity, that'll go on to heal, and I'll address that a little later as well. So what about the acute traumatic spondylolysis? Well, interesting enough is how do I make this diagnosis? Typically, it's usually through the MRI, and what I do see is an actual hematoma in addition to the inflammatory response that you see in the bone and the pars. And it's this hematoma actually that I found that can actually present with radicular symptoms that do typically resolve as the fracture. Because again, that hematoma may actually be in the foramen underneath it. What's the treatment? I actually treat it similar to other traumatic spine fractures, so I'll typically brace for 3 months. I don't jump on the physical therapy that we'll go into in the non-acute. And I'll typically wait for physical therapy until about 6 weeks post-injury to allow for some healing to occur. So what's the non-operative management for the prototypical patient that comes in to see me? That's really a stress reaction or spondylolysis that's been going on for anywhere from 3, 6, 12 months, if not longer. I really is a process of 3 things that I explain to them, 2 of which I think are pretty mandatory, and the third one will be optional, as I'll talk about. And that is one, I restrict all activities that cause pain. That typically, unfortunately, includes the sport, which they are, about to have the most important tournament or game of their life in the next week or two. I do allow for exercise. It's not about sitting on the couch and not doing anything, and that'll typically be swimming or biking. But if biking on concrete or on asphalt is what causes them pain, then I tell them to transition to stationary biking. As for physical therapy, there are specific exercises that's typically employed by the physical therapist, and a lot of these are avoidance of hyperextension exercises. So what about the brace? This is the one that's optional. It's an LSO corset, typically for 8 to 12 weeks. And really, in my mind, the purpose is to limit activities. It's actually really difficult to control lumbosacral junction. And there are anti-lordotic braces and things like that. But again, typically in an upright position, it's not what's causing them symptoms. It's really the hyperextension. So what are the treatment outcomes for this patient population? Really from a non-operative treatment of spondylolysis in, the child or the young adult, the success rate is really high. So, the success rate can be as high as 85%. And, what was interesting and why I talk about the brace being optional is in this meta-analysis, braces did not seem to affect that success rate, whether they were, and it's likely probably compliance related. And again, how it doesn't necessarily immobilize where the most common spondylolysis is. What's actually really important in this process in educating with the families and the patients is that clinical success rate and radiographic union rate are discordant. They are not the same. And if you have to set this up early in the process that you are not looking for the X-ray to heal. This can be as reported as, as low as 18% for bilateral pars. And so if that's the expectation, you're setting yourself up for 3 months later when you see them back for failure. But if you tell them that their symptoms are going to resolve and they go back to their activities, that again is an 85% success rate. The next follow-up question comes, well, what's the long-term outcome? And what's interesting enough, I think this does reflect, 2/3 of the patients will really have continued same or higher athletic activity. Patients will have a recurrence of symptoms, but they will remember what it takes from their prior experience to alleviate those symptoms sooner rather than later. And really only about 1/3 of them will actually require additional treatment, maybe a repeat bound of physical therapy or in extreme cases, operative. The risk factors are female and obvious multi-level spondylolysis.